Hi everyone. So today I will be discussing the Fugl-Meyer assessment of motor recovery, also known as FMA. And it is important to note that I am focusing on the upper extremity of the assessment, although there is a lower extremity function of the assessment as well. So here is my table of contents, and it includes the purpose, the diagnosis and conditions, description of outcome measure, equipment required, scoring, normative data, psychometrics, and references. So the purpose of the FMA is to evaluate and measure recovery in post-stroke hemiplegic patients. It is used in both clinical and research settings, and it is one of the most widely used quantitative measures of motor impairment. So, the diagnosis and conditions that this assessment considers is extremely focused on stroke recovery. The populations include stroke or non-specific patient populations. So, the areas of this assessment focus on ADLs, functional mobility, and pain. The assessment type is an observation. The cost is free outside of the cost of the equipment that you will need for the assessment. And there is no required training outside of reading an article or a manual that comes with this assessment. The age ranges from adolescent all the way to elderly adult, and it takes about 30 minutes to administer this assessment. So the equipment required for this assessment includes a tennis ball, a small spherical-shaped container, a tool to administer reflex tests, and enough space is needed for a patient to move around freely, and if possible, the space should be quiet, a private room with few distractions. For my recording purposes, I didn't use a tennis ball, I used a golf ball instead, and I didn't use a tool to administer reflex tests, I just used my hand. So there are 5 domains assessed, and they include motor function, sensory function, balance, joint range of motion, and joint pain. In the upper extremity, we don't focus on balance, but the subscales can be administered without using the full test. So items are scored on a 3-point ordinal scale, and 0 means that they cannot perform, 1 means they perform partially, and 2 means they perform fully. So I just wanted to show you guys what the scoring sheet looks like for the FMA, and the way you interpret it is based on the overall score. And if a person scores less than a 50, then they have severe impairments. Someone who scores 50 through 84, it shows that they have hemiplegia, and hemiplegia is not a progressive condition, nor is it a disease. Between 85 and 94, they are considered moderate and have hemiparesis. And between 95 and 99, their score shows that they have slight motor discoordination. And here we have some normative data at baseline, 1 month, 3 months, and 6 months. So as we know, ICC stands for intraclass correlation coefficient. SEM stands for standard area error of measurement, and SRD stands for smallest real difference. So I am just going to be using the abbreviations as I go through this slide, but for inter-rater reliability, you have these numbers listed here. With test-retest reliability, based on a interval of 2 weeks, you have these numbers here. Concurrent validity, the relationship between the upper extremity functioning of the FMA and Jepson-Taylor hand function was 0.757. The construct validity has excellent correlation. Modified balance subscale on FMA and the Barthel index. I thought that was kind of cool just because I did do the Barthel index last semester. There's excellent correlation with FMA and functional independent measures. For the minimal detectable change, you have the FMA showing 5.2 points for the upper extremity portion of the assessment. And for the minimally clinical important difference, You have a 10-point increase in the FMA upper extremity, equaling a 1.5 change in discharge, and then a 10-point increase in the FMA lower extremity equals a 1.9 change in discharge. But again, I am only focusing on the upper extremity of this assessment. This assessment also has excellent internal consistency, showing an alpha of 0.94 to 0.98 across 4 administrations. I think it is also important to note that the research on reliability and validity of the FMA has been conducted, but the majority of the research has only examined reliability and validity in 1 or 2 domains, not all of them, or either the upper extremity or the lower extremity. The establishment of trustworthy test-retest reliability is also very important for the clinical application of outcome evaluation tools in a rehabilitation environment. And here is just a quick pic that I was able to screenshot from the Shirley Ryan lab, and I thought it was pretty cool just because it shows how the inter-rater and intra-rater reliability has excellent ratings amongst upper extremity, lower extremity, sensation, joint range and pain, and balance. So for the non-specific patient population, the test-retest reliability has excellent total motor score, excellent sensation, and excellent passive joint motion. Inter-rater reliability is excellent as well. There is excellent internal consistency for the wrist and hand upper extremity Fugl Meyer across 2 trials, and face validity, face and content validity for the motor domain are very good. Scaling is heavily weighted for the upper extremity, and reflexes may be overrepresented in the scoring system. Lastly, I thought it was important to note some limitations of the assessment, and they include the sensation, balance, joint range of motion, and joint pain domains have been criticized as less well suited for this instrument given its intended purpose. Joint range of motion may be a confounding variable, so the inclusion of the joint pain domain may be unnecessary. Distal fine motor functions may be underrepresented, and inclusion of subjective items on the sensation of joint pain domains may reduce the measure's reliability. And here are my references. Thank you all for watching.